Athletic Training, the official journal of the National Athletic Trainers Association. My name is Dr. Kara Radzak, an assistant professor at the School of Integrated Health Sciences at UNLV and the host of Jack Chat. The purpose of today's event is to provide an open forum for athletic trainers and other healthcare professionals to ask questions and discuss the recently published manuscript, Tandem Gait Retest Reliability Among Healthy Child and Adolescent Athletes, which is currently available online first from the Journal of Athletic Training. Today, I'm joined by the lead author on the manuscript, Dr. David Howell. David Howell is the lead researcher at Children's Hospital Colorado Sports Medicine Center and assistant professor of orthopedics at the University of Colorado School of Medicine. He received his PhD in 2014 from the University of Oregon and completed a postdoctoral research at Boston Children's Hospital in 2017. He's the recipient of the 2015 NATA Foundation Dissertation Award and the 2019 NATA Foundation's New Investigator Award. In order to make Jack Chat work as smoothly as possible, we ask that you submit your questions in the Facebook Live comment section or as a tweet at JAT_NATA using the hashtag JackChat, all one word. At this point in time, I would like to introduce David. Thank you for joining me today.
Yeah, thanks so much. It's a pleasure to be here to be able to talk about some of this kind of stuff. And thanks to the Journal of Athletic Training for supporting this kind of work to interface with different professionals from different settings about what research is going on.
So to start off, what sparked your interest in tandem gait? What was the impetus for this manuscript?
That's a really good question. So, as a part of my work, as you mentioned, at the University of Oregon, really started off trying to understand concussion assessment. How do we objectively determine whether or not somebody has recovered from a concussion? Quite honestly, a lot of that started back when I was doing clinical athletic training as far as my own interests go. I was interested in, how the tests that we use may not have a high level of objectivity and don't fully assess kind of the full nature of what a concussion is. And so through the work that I did there, we worked in a motion analysis laboratory. So, some pretty highly accurate measures where we were able to measure, within a millimeter of accuracy, how much the center of mass of an individual moves during a gait cycle, for example. And that's, I think, very interesting for those of us that have a strong biomechanics interest, but to a lot of clinicians, whether or not somebody deviates 3 versus 4.5 millimeters or centimeters or, during a gait cycle probably doesn't have a whole lot of clinical value. And, what we found was, I think, interesting that we continue to identify that there were deficits following a concussion among adolescents, but they continue to last longer than something like symptom durations. We see these kind of prolonged deficits, and from there we kind of said, okay, we think that we're onto something, that there may be these kind of what I've heard termed subclinical deficits. So there's something still going on when people are cleared to return to play. The challenge with that was, how many high school athletic trainers do you know that have access to a motion analysis laboratory? There's not a high level of clinical viability. And so that kind of began some of the work that we wanted to still understand kind of complex motor systems, something like locomotion or gait, that is a fairly complex motor task relative to something like a simple reaction time or standing task or something like that. And so from there, we kind of transitioned into, okay, maybe there's some ways that we can measure in a clinic using portable sensors. So there's some commercially available products that, you can measure gait speed and things like that. The interesting thing from there was, well, we can still kind of identify that there are these persistent deficits in your ability to walk, and particularly when you walk and think at the same time. So you ask somebody to walk and subtract by sevens, for example, you start to see some destabilizing effects on gait. And from there, we kind of, we're working with kind of the tools that we had. And one of the tests that was available as a part of the SCAT-3 actually was the tandem gait test. And so over the last couple of years, myself and several other athletic training researchers across the country have started implementing this sort of approach into our studies. And, as a result of that, we've kind of understood that, there may actually be some value to this, and the test is fairly simple to administer, more so than something like a motion analysis laboratory. But it probably gives us a little bit better idea of how somebody's able to move, how their motor system is functioning, than some of the, like a computerized cognitive test is a very good test, and I think it should be a part of standard clinical care, but it doesn't fully encompass everything with concussion. And if you think about what especially our athletes are subjected to, we should test them in a way that they're going to be tested, quote unquote, on the field. And so what do you have to do on the field? You have to move. There's a dynamic movement element to that. And rarely are you ever going to just move or just think. So the dual task part of that allows people to, or allows clinicians, athletic trainers, to identify how somebody is doing both things simultaneously. So you can test motor function, using a tandem gait test. You can test cognitive function in a lot of ways, but how do we integrate those two things to perhaps more closely reflect the sport-specific demands of athletes? And so that led us to then implementing this sort of technique and test throughout a lot of our different studies, and we've seen a lot of benefit to it.
Great. Well, one of the questions we're already getting from the audience is very much related. And we have an audience member who's at a high school, has limited resources, and they want to know what's the easiest way to implement dual task and tandem gait, and kind of combine them together into a tandem gait dual task in the clinical setting.
Yeah, so that's a good question. And thanks to my clinical team here at Children's Colorado, led by Dr. Julie Wilson, who's one of our concussion specialists, we've actually been able to implement this in all of our clinics where we see concussion patients, both acutely after injury, all the way through return to play. So we're doing this system kind of system-wide at all of our locations. Our athletic trainers that are at our high schools are doing it. And it's fairly simple, it's fairly easy, and again, it's within the kind of scope, I would say, of what an athletic trainer is capable of doing. The way that we've approached it is, I think what the SCAT-5 actually recommends is that you put a strip of tape down on the ground. What we've discovered is that the custodial staff doesn't really like that, the tape residue on the hospital floors. And so we actually bought, Dr. Wilson went out to Joanne Fabric and bought a strip of about 38 millimeter wide fabric. And it's 3 meters long, so you kind of have a reference tool, and then you tape it down. And then you have people, if there's an athlete that's concussed, the paradigm is fairly simple. You instruct them to walk in a heel-toe manner along the strip of tape or fabric, down as fast as they can to the end, kind of get across the end of it, turn around, and come back. And the main outcome that we've kind of gained value from is the time from when they start it to when they complete it. So really all you need outside of kind of what you would have, actually everything's probably in the athletic training room, in that maybe you have a timer or a smartphone or something like that, as well as a strip of tape or a piece of fabric that's, $5 at the fabric store. And so what we were able to do from there is now, let me back up. So we'll do 3 trials in the single task, and then we'll take the average of that. We'll get a single task, kind of how long does it take them to complete without a cognitive task. And then we'll have them walk and subtract numbers by 7s or 6s. We'll have them spell words backwards, like a relatively simple, like 5-letter word backwards, or say the months in reverse order, starting from a random month. And we'll do 3 trials of that. We'll take the average of those 2. And the advantage to that is there's a little bit of normalization for each individual. So everybody's going to kind of walk at their own pace. So within the SCAT-3, I believe, they said 14 seconds is kind of cutoff of pass-fail. And what we're realizing, there's a study published in the Journal of Athletic Training last year, I believe, by the group at University of Georgia, Rob Lionel and his group, and found that it was that kind of cutoff was probably not appropriate for the younger age group. And so by adding a dual task, you're actually able to compare directly of when somebody is walking and then when they're walking and thinking at the same time. So it's kind of a measure of cognitive reserve. And what we're able to see is, okay, it takes you 15 seconds in a single task condition on average to complete the test, and 20 seconds on average to complete the dual task and condition of the test. You can kind of calculate the percent difference and get a dual task cost and kind of get an estimation of how somebody's doing relative to themselves if you've done a baseline test. And we're working on ways to develop normative data sets as well, so that you can kind of place those values in context. Because I think one of the challenges where we're at right now is we started implementing this here, and some of the athletic trainers would come to me and say, well, you know, somebody completed the test in 16 seconds. What does that mean? Right. And I think within an individual, it is worthwhile to track their progress over time. I think quantitatively, if you have somebody do it, there's an element of clinical judgment that somebody could say, you know, I'm looking at you and you're completely unstable when I'm asking you to walk and think at the same time. What's going to happen when I put you back into sport? And I don't think it's ever going to be a end all be all the test by any means. I think it's perhaps an augmentative clinical tool that might measure something that you're not currently measured within the context of also doing an ocular exam and maybe a BESS exam and a cognitive exam and a symptom score. All of that, I think, can paint a picture, and this is kind of one piece with that.
So you're really looking to see how they change from the single task to the dual task if you don't have a baseline.
Yeah, and again, I don't have we're still fairly early on in this. I don't have a firm answer of, you know, this is what, you know, 4% change versus a 10% change means. But that's one thing that we're interested in understanding. And I do think that there's probably some value in just taking how long did it take you to do this test? Did it take you 30 seconds to get down and back? We've had some kids come in that are, you know, maybe 7 days post-injury and it's taking them almost a full minute to complete it. And, you know, you think you really just have to walk 6 meters. It's, you know, 3 meters down, 3 meters back, but they're unable to really accommodate for both of those things. And you see that they're really struggling to just put one foot of it in front of the other. And I think it reflects kind of where they're at right in that moment. And then some of the other things we're looking at is, you know, is there potential prognostic value to it? We're fairly early on in that research, but we have some promising kind of early results, I would say, nothing that we've published yet, but will hopefully be forthcoming in the next year to identify if you do this test, you know, maybe 3-4 days post-injury, and there's certain thresholds that we can identify. Is there actually some value in saying, well, maybe you're one of those people that's at risk of developing persistent symptoms? So more to come on that, but that's certainly what we're looking at.
Great. Another thing that we had an audience member ask about is, how can tandem gait help us understand the athlete's injury or re-injury risk after return to play following concussion?
That's a really good question. And so, you know, I think maybe to step back a little bit for those that maybe don't follow the concussion literature as closely as I do. So what we're realizing right now is that a lot of epidemiological evidence from youth athletes all the way through professional athletes has shown that when you get a concussion and you go through the normal clinical care and you have been documented clinically to recover, they send you back out to sports. Over that next year, you're at a higher risk of sustaining a subsequent lower extremity musculoskeletal injury. It's kind of the primary area that the research is focused on. And there's probably a lot of different approaches that we can take. One of the theories that we've kind of been operating under, and there's several valid theories that are out there, but perhaps our clinical tools aren't equipped to identify whether or not somebody is fully recovered in their ability to control their neuromuscular system, their tensional system, and safely execute kind of motor tasks. And, you know, kind of an example would be, you know, if there's a lingering deficit that we're not testing for, and, you know, there's a football player running across the field and he isn't able to react to a leg sticking out, and he trips over it and ends up, you know, separating or rolling his ankle, or, you know, falling over and getting you know, some sort of strain or something like that. Perhaps there's a way that we can test for it. And I don't think that our clinical tools that we have right now, again, kind of the standard clinical approach, are able to successfully screen for that. And I won't give away anything, but I know that there's some data that exists that will hopefully be published soon that I'm not a part of, but I've kind of been aware of, that really suggests that the current clinical tools aren't successful at predicting these sorts of injuries. So can we implement more complex motor tasks that are more reflective of sport specific movements and combine them with cognitive tasks? And again, this is one paradigm of potentially several. And we think that this might actually give us some prognostic value, not only for concussion recovery, symptom recovery, but also for kind of long-term, are you still able to complete 2 tasks at once? Does that then relate to your ability to avoid further injury? But more to come on that. We're still early days here, so I don't want to promise anything.
It's definitely an emerging area of research, that's for sure. So moving on to another area of expertise that you have is pediatric concussions, particularly. So how do concussion symptoms and evaluations differ between adults and children, adolescents, pediatrics? Are the outcomes similar?
Yeah, so it kind of depends on how you define pediatric, adolescent, child. They're sometimes used interchangeably. We've done some kind of multi-site work looking at different symptom profiles across different age groups and finding that the way that people present and the kind of the most common symptoms that maybe a 8-year-old will complain of versus a 15-year-old versus a 20-year-old are probably different by groups. Different groups of symptoms probably have different levels of predictive value. Right. And I think a lot of it has to do with the scale that you assess symptoms with. Part of the problem may be a little bit stronger word, but difficulty, challenge, especially in research is there's so many different symptom scales. What do we use, right? And so I think that there's the SCAT symptom scale, the PCSS, that has the child SCAT, which is up to 12 years of age. There's kind of a adjusted set of questions, and rather than a 0 to 6 scale, it's a 0 to 3 scale. There's also the post-concussion symptom inventory, which is similar, has been validated down, I think, as young as 5 years of age. And so I do think for that younger age group, those 5 to 12-year-olds especially, we need to consider them, that they can't answer the same types of questions. They might not know what, how severe is your nausea at this point, for example. They might not be able to perceive that. They might give you a different response. And then actually another study that we have, I think, forthcoming in the Journal of Athletic Training that's been accepted, looks at the agreement between patients and their parents, and seeing that actually children, the younger kids, tend to agree with their parents if you assess them separately on symptoms better than adolescents. And, we have kind of some conclusions from there. But we do need to treat all these age groups quite differently, both in our assessment of symptoms, but then long-term, as far as just how we treat the individual. We can't treat a 13-year-old the same way that we would treat a 25-year-old.
So what would your immediate take-home message be for somebody who wants to modify their clinical practice? They're working with a pediatric or adolescent population. What are some immediate steps? Change the symptom checklist you're using, potentially.
Yeah, definitely. I would look into it. What makes sense in your practice, whether it's, the 3, I think, most common in this area are the HBI, health behavioral inventory, the PCSI and the PCSS, and kind of look through what those questions look like and what make the most sense to you. Because as a clinician, I think that you need to be able to explain to people, what are we actually asking you, if there's any sort of ambiguity, but realizing that there are some scales that are adaptable for that younger age group that are probably more appropriate than them, and people that are way smarter than me that have developed these things in order to really hone in on that population, and kind of using some of the work that they have done. I think that it's going to be up to you individually and what makes the most sense within your clinical practice, but I would definitely look into those specifically for that younger age group.
What about immediate treatment? So past the evaluation, now in that immediate treatment phase, differences between pediatric, adolescent, and adult?
Yeah, so a lot of the, kind of, I would say the way that we've moved, with the latest Berlin guidelines, is that after that 24 to 48 hour period of rest, we don't want people to sit in a dark room by themselves. The kind of this cocoon therapy has kind of gone away. Hopefully in most settings, we still hear about it happening, but I think it's a lot less prevalent. And it makes perfect sense that if you take especially a high school kid, and you remove them from all their normal activities, then they're going to get the same symptoms as a concussion, even without a concussion. They're going to be irritable. They're going to have trouble sleeping, all those kinds of things. I think as far as treatment goes, so if we want to talk about active rehabilitation, the things that drive those people, what are their motivations for getting back might be quite different between an adolescent and an adult population. For instance, a lot of the research that we've seen shows that, these high school kids, one of the things that stresses them out is schoolwork. They've got SATs coming up and college attendance, and they're worried about falling behind. That's a very different type of approach than somebody that maybe is an adult and wants to get back to work, or maybe they don't want to get back to work. So treating those like kind of that initial, what are you trying to get back to? Obviously, sports is another part, very relevant to our population. Mm-hmm. But within treatment, I think there's some really good work coming out from multiple centers. I think championed by John Letty at the University of Buffalo, looking at early kind of sub-symptom threshold activity, where we have people exercise to a point where they're symptomatic, and then we kind of recommend that they do a exercise routine that's a little bit below that. And that a lot of that work has been done in children specifically, or adolescents at least. As far as the specific differences, I think it's gonna vary from setting to setting, but getting to know what the goal of the patient is and trying to match that. I think exercise early on is probably pretty safe to do, as long as you don't exceed some of those things, symptoms, and try to make them a lot worse. But beyond that, I think again, we're, as far as physical therapy, different types of manipulations and looking at neck pain and all that kind of stuff. I think there's some strong research in that area, but that's primarily been in adults.
So is there anything that's commonplace in adults that we should not be doing, that's not appropriate for pediatrics?
Oh, that's a good question.
It's kind of different, but
yeah. Nothing I think comes to mind. I say that we kind of need to approach them in a similar fashion, right? Mm-hmm. In a different fashion. You can't treat children like little adults, and I think a lot of that goes into what's happening during adolescence, and that rapid neurodevelopment, I think, is something that we really need to take care of. I think that it's likely that adults might recover a little bit faster than adolescents, and that's probably because probably due to a lot of different things. But to be able to compensate for the time of rapid neurological development, it takes a lot of effort. And so I think that that's something that we definitely need to be acutely aware of, and the kind of the pressures on these different age groups and what their population is. Obviously, there's different from a professional to a high school athlete, but putting things in the context of, if you don't report your concussion and you try to keep playing through it, we know that you're going to probably have a more severe injury. It's going to take you longer to recover. And a lot of that education work has been focused both on the collegiate, but then also on the high school population. Again, people that are within our athletic training community are working on that aspect and have done some brilliant work, and trying to understand what the motivations are for each different group is, I think, very important too.
So you're leading right into the audience questions wonderfully. One of the things that somebody's asking is, how would you approach parents and adolescents with conversations related to the potential long-term repercussions of a concussion? This is coming from our Facebook page.
Yeah. So I think it's a valuable conversation to have. I think that, again, I've said this a few times, we're still in the early stages of understanding the seriousness of concussion. I think a lot of the early research on concussion came from college athletes, and as I've said, that's not the same as high school athletes, both in their body maturity as well as their cognitive maturity, their developmental processes and things like that. I think that there's probably a balance, right? And we've seen the pendulum swing over the last 2 decades quite a bit, where concussions aren't, oh, you got one, just keep playing anymore, right? That was maybe 20, 30 years ago. A lot of people kind of adapted that. Perhaps the pendulum can swing to a point where now if you get a concussion, that's a life sentence to, you're in trouble, you're never going to recover, you're sentenced to a life of, dark depression and despair. Obviously, if that was the case, then everybody who ever got a concussion would not be doing anything successfully. So I think the conversations that happen between clinicians and patients and parents has to be an honest one about what we know and what we do not know, and understanding that one concussion that you suffer, as a high school athlete, if you're a cheerleader, for example, that's probably a lot different than somebody who's suffered 15 or 20 by that stage in life, and trying to understand, especially in those people that have more fear, maybe if they've had several concussions, and what those kind of red flags are. Obviously, we know that there's not a single number where we say, okay, well, now you've had 3 concussions, that means you can never play any sort of sport again. That's not the approach that I would recommend. But looking for those kind of warning signs of, are concussions happening with greater frequency? Are they happening in, the first 2 that you had happened a year apart, and then the next one was 6 months, and the next one was 3 months? Or the magnitude that's required to cause a concussion. So the first one was a big one, and then the next one, you were vacuuming and you stood up and hit your head, and that gave you a concussion. Those kinds of things. Perhaps there's a vulnerability, and perhaps there's something in your playing style that's making you predisposed to that. I think those types of questions and trying to understand why are they happening? Why are they perhaps getting worse? And the other thing I think is the duration it takes you to recover from each one. So if the first one took you a week, and then you had another one, it took you a month, and then another one took you 3 months, trying to uncover why that's happening, and make recommendations based on those types of conversations.
So really having an open dialogue with it.
Yeah, the physicians that I am able to work with, I see it firsthand every day. They're brilliant in that the conversations are very two-way, very open. Ask me questions, I'll be very honest with you. Mm-hmm. And I think that's, there's no kind of beating around the bush, but then there's also no like fear mongering that this is the worst thing that's ever happened to you and it's going to take you 5 years before you're all the way better, kind of a thing. Yeah. Trying to understand that balance, I think, is very important at this juncture.
So we have another Facebook question for you. Since your work has shown the 5P prediction rule is useful in a sports medicine setting, what are the greatest takeaways for clinicians when considering using this tool?
Yeah, so for those people that don't know, so the 5P tool was developed by a group of physicians in Canada in the emergency room, led by Radzak. And it is, the way that they did it, I think, was brilliant. And if you want to look up the study, it's published in JAMA, and it's a very well done study in that they took as many clinical measurements as they could think of at the time of injury, and kind of developed this risk score and then validated it in a separate cohort of people. So a really rigorous study design. And what they found was, of all these different measurements that you take within the acute kind of first 48 hours of their injury, there are 9 variables that kind of predict whether or not somebody is going to go on and have persistent symptoms. So symptoms lasting for more than 28 days post-injury. And there was a score that was developed out of that. And I won't be able to recite them all off the top of my head, but things like age group, sex, concussion history, and then specific symptoms like fatigue, headache. And then there's one kind of balance aspect where you do the tandem stance of the best. So you stand with your kind of feet like that for 20 seconds. You count the number of errors they get. From that, you can derive a specific risk score and stratify people based on kind of what they score on that. And so if somebody scores, for example, a 9 to 12, that means they're at a very high risk of sustaining a concussion, or excuse me, a prolonged concussion symptom duration. And so what we've been able to kind of replicate that in the sports medicine setting, and found that same tool was pretty worthwhile. But again, it was kind of a retrospective study. We're hoping to kind of launch a couple of different projects related to this. I think that the biggest takeaway for me at this point is if we can identify those people early on that are the most likely to be showing up, 2 months later in these complex concussion clinics, And we can find treatment pathways for them earlier on, even if that's like a structured exercise program, some education, and maybe seeing a physical therapist or an athletic trainer that somebody is at least helping kind of counsel and talk them through that. Okay, maybe you're at a higher risk of these persistent symptoms. What can we do about that at this point? I think that the tool itself it was intentionally designed to be simple for any clinician to do. And, we've done a little bit of that in our clinics, but I think most athletic trainers in their setting, if they see a kid, a day or two post-injury, they could implement this in 5 minutes or so. A lot of the symptom questions they're already asking about, a lot of the demographics and background information they're already asking about. So it's just a couple additional things that are fairly straightforward to screen for. And again, I would, at this point, it's still a screening tool. It's not, oh, you get a 12 on this, you're 100% going to go on and get persistent symptoms, but it's at least a tool to recognize who's at risk for that and perhaps get them into treatment sooner.
Great, thank you. So a few really good immediate take-home, change your clinical practice tips. Thank you. Mm-hmm. So just to kind of wrap it up, what are you most excited about with this evolving area of concussion research?
Yeah, there's so much, I think, excitement, from a research perspective, particularly in the population that I work with, which is pediatric and adolescents. As I mentioned earlier, a lot of our initial research happened on college campuses, as it often does. And as a result of that, we know a lot about college athletes. The adolescent athlete, and especially the younger, 12 and under, we don't know a whole lot about. So that's one thing that I'm really excited about learning more is, how do we treat these kids and, beyond symptoms? What sorts of tests are better for the younger kids than the older kids? And what are the factors that predispose them to these prolonged recoveries? The other kind of really exciting thing as a researcher and somebody who has an interest in biomechanics and neurophysiology is the advancement in technology. I think that while we're kind of still developing a lot of ways to assess a lot of different things, it's good in that there's kind of more ubiquity, right? So we can use things, we're working on some ways. I kind of mentioned that, we're testing gait, but we're working on ways that, okay, how do you actually, instrument that without a huge demand? Can you use your smartphone, for example? There's some highly sophisticated tools in your pocket right now. And so we've got some funding to get going on some of those types of projects. I'm also working with some colleagues that are brilliant neuroimaging specialists, and they're leading the way on understanding, what sorts of signatures can we identify in the brain after concussion. And beyond that, we can find these microstructural or neurochemical changes, but how does that then correlate with some of these functional tests that we talked about? And then how does that impact clinical care? And then at the same time, until we have a firm understanding of what our therapeutic targets should be, we really can't administer therapy with a complete understanding of what's changing. And so identifying, specific centers or chemicals or, whatever it is, being able to say, okay, there's a change here, this correlates with something bad or some sort of poor outcome. Now, how do we implement some sort of change in our rehabilitation to actually target that area? And then I think the other thing that's really exciting about technology now is that it enables us to work in a multi-site fashion. I'm very fortunate to work with colleagues across the country and actually all over the world on different projects that we're able to kind of enact the same type of systematic approach, conglomerate data in a way that's systematic and it's able to be synchronized across sites. And then we get information about not just high school kids in the greater Denver area, mm-hmm. but a geographically and hopefully ethnically and everything diverse population. And then from there, the long term, and I usually say this in most of my talks, is that my goal is to put tools in the hands of athletic trainers that don't have the resources that somebody at a large medical institution like me has. Understanding the processes behind that, but then that high school athletic trainer that has a pretty small budget and not a lot of space and oversees care for 3,000 kids, how do we actually equip them to really truly understand what's happening after concussion and make the right decisions. So all of those things I think work hand in hand, but that's definitely what we're working to accomplish in the years coming forward.
Great. Thank you so much. I really appreciate you joining us today. And again, your work is available online first at JT. Please feel free to go on and read it. It's a wonderful read. We didn't get a chance to go into it too much today, but you gave us some wonderful take-home, immediately implementable clinical resources. So thank you again so much, Dr. Howell. And thank you everyone for joining us on Chat.
Great. Thanks.